criteria for allergen immunotherapy, or AIT. Today, however, we continue this journey with new expert speakers who will share fresh perspectives and insights to further deepen our understanding of these evolving fields. I can see that we have a diverse audience today, including many of those who joined us last session, as well as new attendees. So as last time, I encourage everyone to actively participate by asking questions, sharing your thoughts, and making the most out of this interactive learning experience. So with this, I will now hand over things to Dr. Muhammad Abu Zaqouq to introduce the program to you and to introduce today's speakers. Thank you again, everyone, for joining, and I hope you find this session valuable. Dr. Muhammad, the floor is yours.
Many thanks, Muad, and Assalamu alaikum. Good evening, everyone. First, I'd like to thank you for sharing part of your evening with us tonight to learn about allergen immunotherapy. We have a very exciting program with expert speakers. But before we go on, again, just to reiterate some points that Muad said, this is a webinar series, a collaboration between the Gulf Academy of Allergy and Clinical Immunology and Stallergen Greer Biopharmaceutical. The aim of this webinar series actually is to address different aspects of respiratory allergy and allergen immunotherapy, which is an important therapeutic area in allergy that's not really very well understood. And there are a lot of myths and fictions, if you like, and unmet needs, particularly for non-allergists. The program is a 6-month webinar series. Each session features a different national, regional, or international expert in the field of allergy and clinical immunology, and lasts about 1.5 hours to 2 hours. Of course, your participation is really essential so we can learn from your experience, answer your questions, and share your concerns as well. So please type your questions in the Q&A section to go through your questions, comments at the end of the talks. Now, just a quick, for those who don't know anything about the Gulf Academy of Allergy and Clinical Immunology, this is really a very interesting initiative that was established in 2022, spearheaded by the Cleveland Clinic team. And basically, the vision and the mission of this initiative is to provide high-quality educational activity, foster collaboration among healthcare professionals, promote the best practice to promote patient care in the Gulf area. And although we're a very young organization, but we've done lots of things in terms of education, and the last but not least was our Allergy and Clinical Immunology Conference, the 4th Allergy and Clinical Immunology Conference, probably the largest in the Gulf area. Now, of course, everyone knows Stallergen and Greer. Again, it's a global company specialized in allergy diagnostics and treatment, particularly allergen immunotherapy, and over a century of experience in allergy, offering end-to-end approach to therapy, if you like, particularly AIT products to our patients. The main focus of Stallergen and Greer is on producing natural extract that mimic real-life allergen exposure, to make sure that patients, when they're given immunotherapy, the symptoms were reduced because the allergens were given them mimic what they're exposed to in nature. Now, the Allergen Immunotherapy Without Borders is a program that led by international experts, pioneers in allergy care. And again, the program, as I said, delivers our aims to deliver the latest evidence-based approach in respiratory allergy and allergen immunotherapy. There is a list of topics there that we've managed to put together with the help of Stallergen Greer, and they address a lot of aspects of allergy and allergen immunotherapy. And you can see that these sessions are led by lots of experts in the area, regional, national, and international experts. And tonight's session is the second of the sixth webinar series, if you like. Now, we've learned last time that allergy we've learned lots about allergy diagnosis and management, and we've there is no doubt that taking history is really essential, and this is the key part in allergy diagnosis. And of course, you're helped by other tools, including your skin test, your allergen, your specific IGs, and of course management of allergies, allergen avoidance, of course, symptomatic treatment, and allergen immunotherapy. We've learned that pharmacotherapy has limitations, and maybe allergen immunotherapy is an important tool to be used in those patients with specific allergies. We've also learned about allergen immunotherapy efficiency, if you like, and we've learned that although this treatment modality is really, really very important, but it relies on patient adherence and commitment to this form of therapy. And of course, patients should be on board when you're offering these therapeutic modalities, so for this therapy to be successful. Tonight, continuing on the same theme, we're going to address a very specific allergy, and this is grass allergy treatment, and it is case-based insights. So again, grass allergy is quite a significant issue in our region, and it varies from one part of our region to another. And it has its specific unmet needs in our region as well. We have two eminent speakers to talk to us tonight, and the two talks there is allergen immunotherapy in medical practice and how to manage patients with comorbidities. And the other talk is going to be about allergen immunotherapy in a polysynthesized patients with asthma. And this is really, both lectures address two important aspects because, again, polysynthesized individuals are really a therapeutic dilemma when it comes to managing their symptoms. And, there are a lot of issues, and, it's, identifying the key allergen is really very, very important in polysynthesized individuals, particularly those with asthma. So we're going to learn tonight about all of these aspects. We have two eminent speakers, Dr. George Jobalikinian, who is a visiting associate professor of clinical medicine at AUBMC and past associate professor of Permanent University. He's a former president of the Lebanese Pulmonary Society and head of pulmonary and critical care at St. George's Hospital, UMC. He's American board certified in pulmonary, sleep, and critical care medicine with a training in Cleveland Clinic. He published extensively in respiratory medicine, including COPD, allergy, and critical care, with a significant contribution to allergen immunotherapy. Our other speaker is Dr. Khalid Al-Asad. He's from Jordan. He's board certified, a specialist with more than 30 years of experience. He's trained in Boston University School of Medicine. He directs medical ICU at the Arab Medical Center and teaches at the University of Jordan, focusing on pulmonary medicine. He published top journals and conducted research on allergy and allergen immunotherapy, along with other respiratory conditions. Dr. Asad, an active member of the American Thoracic Society and the European Society, and he has served on key committees like the Jordanian High Council of Health. So we have two eminent speakers addressing two important issues related to allergen immunotherapy. I think without further ado, I'd like to invite Dr. Georges to deliver his talk. So Dr. Georges, the floor is yours. Thank you.
Thank you, Professor. Let me see if I can share my screen. I'm still,
Let me
I
stop
think
sharing and then I'll let you.
yes, please do. Thank you. So let me do that.
We can see your screen, Dr. George.
Excellent. So good evening, everyone. Thank you, Professor, for your kind introduction. It's such a pleasure and an honor to be addressing this cohort of colleagues regarding issues that I think, as Professor Muhammad mentioned, until recently were intertwined with myth and all sorts of misconceptions. So we're gonna hopefully be able to, Khalid and I, try and clarify a few of those important issues. I will start with AIT in medical practice, the possibilities of use in a patient with a comorbidity, and it's a case that involves a pediatric patient, Sam, a 10-year-old, who him and his father arrived for an appointment about maybe a year and a half ago. So he was an early user until the age of 4, and since the age of 5. He had been diagnosed with atopic dermatitis with exacerbations in springtime. Since the age of 7, bothered by itchy eyes, watery eyes, and nasal congestion in spring as well. Family history is important. I think that's one of the elements that I would like to emphasize, that anytime I see a patient, especially a younger patient, I can figure out usually from the profile of the young adult or kid, the profile of the parents. So the father actually has bronchial asthma, and he was followed by a pulmonologist. The mother did not have any history of allergic problems. The younger sister is suffering from eczema. The Sam lives on the second floor with no carpets, pets, or humidity. And the manifestations, obviously, you can guess. You have the all the different symptoms, from the nose to the eyes to the lungs with the wheezing, the skin manifestations. He has the atopic dermatitis problems, and oral, which are things that do manifest as time goes by. So, if I were to ask you, what would you say the most bothersome symptom in children is? What would you think? Would you think it is the nose that's responsible for the most bothersome symptom or symptoms, or is it the eye responsible for those symptoms? And actually, it was something that I kind of was a bit surprised, because, I'm a mostly an adult pulmonologist. I do see kids for allergies and bronchial asthma, but I was also surprised because it turns out that it's different between the pediatric and the adult population. So a study that was published in 2016 in Pediatric Allergy and Immunology looked at the comparison of outcome measures in allergic rhinitis in children, adolescents, and adults. And it was a study that was, if you will, an eye opener, because it turns out that the ocular pruritus, or the itchy eyes, are the most common or the most bothersome symptom in the pediatric population compared to the adult population. Whereas rhinorrhea, for example, take the driver's seat, and in the adults, and sneezing as well. So if you look at it, you will find that the ocular symptoms, especially the ocular pruritus, is the most bothersome symptom in the pediatric population. Something we need to keep in mind whenever we're actually addressing such an issue in that population. Going back to our patient's profile, that's Sam's skin prick test for respiratory allergens. And as you can see, judging from the positive controlled histamine with a wheel of 4 mm, he showed significant sensitization to the three kinds of grasses: Timothy grass, meadow grass, and ryegrass. He was also sensitized to other things in a minor format, but lo and behold, was really three different grasses. When we tested him for allergy and for his asthma, his FeNO, the fractional excretion of nitric oxide, came back normal at 13 parts per billion. And if you can look at his on the right hand side, I know the numbers are not clear, but that's not important. The curve actually is clear, the flow volume loop, and Sam does not suffer from an obstructive process. His spirometry is normal and did not change post bronchodilator challenge. So, in summary, spring symptoms for the last 5 years with manifestations of dermatitis and later symptoms of conjunctivitis and rhinitis. He was on the usual treatments, that's topical corticosteroids, the antihistamines, relieves the rhinitis symptoms, obviously, but not very effective when it comes to the ocular symptoms, which we just said were more bothersome in the pediatric population compared to the adult population. These symptoms are having a significant impact on Sam's daily activities. The lung function is normal, so he does not have concomitant asthma, something that is quite common. So, thankfully, only about half of patients with allergic rhinitis suffer from asthma. It's not the other way around. With people that have asthma, the majority also suffering from allergic rhinitis. So Sam is sensitized to grass, timothy grass, meadowgrass, and ryegrass allergens, and he has associated atopic dermatitis. So, do we need to wait, or should we give him AIT? All right, so I think this is the question we're going to try to answer because, as you know, there is something called the atopic march. So, time is really not on our side in that respect. Some people, not all, obviously, but some people are at risk of increasing sensitization and worse allergic process over time. And that's an important thing. So, you have eczema, you have food allergies, then you have allergic rhinitis, and you have concomitant allergic asthma, and you end up with the oral allergy syndrome. And those are important to keep in mind because this atopic march has enough evidence behind it to make us really consider time as an important element in the decision of treatment in patients such as Sam. So, children with eczema, early sensitization, and a history of atopy in parents have a significantly increased risk of developing subsequent allergic respiratory disease. And again, the immune system is more flexible and capable of changes and modifications in the early clinical stages of allergy compared to later stages, something we need to keep in mind. So, the more you wait, the more complex the problem becomes, and the more sensitized and allergic the patient becomes. So, evidence suggests that AIT in children and adolescents with AR may be protective against the development of asthma. Now, that's not just me saying so, it's actually something that has been proven in the major bodies worldwide. So, the WOW, World Allergy Organization, I always thought that was a cool name. The preventive benefits of AIT may be greater if initiated early in the course of allergic disease. This is from a study by Walter Canonica in World Allergy Organization Journal 2014. Yaki actually found also in a study by Roberts in Allergy 2018 that a 3-year course of AIT reduces the likelihood that children and adolescents with AR driven by pollen allergy go on to develop asthma up to 2 years post AIT. And that's important. I will go back to that later on in detail regarding the carryover effect. How about ARIA? ARIA found that in children, AIT may prevent the asthma onset in patients with allergic rhinitis. That's a study from Bousquet in Allergy 2019. And much more recently, this is only a few months ago, in I think July of 2024, the impact of liquid slit on asthma onset and progression in patients with allergic rhinitis. This is the efficacy study by Pascal Demolay. And the conclusion is that slit liquid was associated with a significant reduction in the risk of asthma onset or worsening. Now, this is also an important study. Why? Because if you look at the patient population, you have close to 450,000 patients, 112,500 slit liquid patients, and 333,000 controls. So we're not talking about a small cohort of patients. We're talking about a huge population, giving it more weight and adding to what is already built up as evidence towards the initiation of AIT as something that can impact the progression and the development of asthma in the affected patient. So really, they don't have much time to waste. AIT guidelines on allergen immunotherapy, allergic rhinoconjunctivitis or ARC. So general indications, AIT should be considered when all of these criteria are met. Symptoms strongly suggestive of allergic rhinitis with or without conjunctivitis. Evidence of IgE sensitization, so either positive skin prick test and or serum specific IgEs to one or more clinically relevant allergen. Mind you, an important element that I think was discussed in the previous session was that you can be sensitized but not allergic. So the clinical picture is very important, has to be clinically relevant. All right, so it's very important to keep that in mind. Experience of moderate to severe symptoms which interfere with usual daily activities or sleep despite
We can't hear Dr. Joris. Hello?
George, can you hear us? يبدو في weak connection and Dr. George.
Yeah. Do we have a WhatsApp number for him?
Yes, I do. Let me just send to him. I'm sending right now.
Till we get Dr. Joris back, I think this is very important. So sensitization versus allergy. You know, sometimes what happens is that we do lots of allergy testing, or what happens is a lot of the time we get people came to us for second opinion, and they had lots of allergy testing outside our institution, and then it's not allergy really. Only few relevant allergens are really the cause of patient's symptoms. So it's really allergy testing has to be tied in with the symptoms. Okay, are we back to Dr. George?
Yes. Yeah. I don't know what happened. So
no problem.
Yeah. Can you guys hear me?
We can. Yes.
See your
Okay.
screen.
So let me see if I can.
Can you go back a few slides, please?
Yes, sir. So no, we were here. I think you're hearing me. I think along to this slide. So essentially, I was saying that.
Yeah.
So that standardized AID products with clinically documented evidence of efficacy should be used. So having said that, we really have to progress in terms of the initiation of AIT in the appropriate population, because as we know, I don't like to call the drugs that we use, the pharmacotherapy, symptomatic treatment. They are important for symptoms, but I like to call them controller medications. They do control the symptoms to some extent, but they do not halt neither the progression nor the development of further sensitization. In that respect, I think it is important to reiterate to our patient population that whenever we're talking about desensitization, we're really looking at modifying the disease itself, the underpinning of disease. In other words, achieving something that until only a few years back was not achievable, which is cure. So it's important to keep that in mind. And satisfaction with disease control is not a reason not to use the potential for the pathogenetic and steroid-sparing effect of AIT. So a very important element that I use when I discuss my patients' treatment options, whenever I talk about AIT, I talk about from the perspective of disease modification, and that's extremely important. I had mentioned the efficacy study regarding the delay and in the progression and the prevention of asthma development and further allergies. And this is the same study looking at what happened with the controller medications whenever you add the SLIT, sublingual immunotherapy. So if you look on the left-hand side, you will see that you have the grass pollen SLIT treatment period and then the post-treatment period. If you look at when you're giving the sublingual immunotherapy treatment, you will see that there is a reduction in the antihistamines and the intranasal corticosteroids dispensing in SLIT patients during the 4 follow-up periods. Each follow-up period was 2 years, so you have an 8-year divided into 2-year periods, so 4 periods. And it actually followed the patients for a 4-year or 2 follow-up periods post-treatment. That's why it's important, because it showed that there was a maintaining of the reduction in antihistamine use and intranasal corticosteroids. So over time, allergic rhinitis treatment dispensing significantly decreased in grass pollen SLIT patients with a reduction maintained post-treatment. And in the control patients, and that's important, there was a global increase in the antihistamine dispensing over time. So not only are we achieving a better control, we are actually reducing the need for medications, and this is maintained in the post-treatment period. So I think it is important to now state clearly that we do need AIT, and I think we have enough evidence behind it. So it's important to consider all the influences of all the attacks that we have. It's not just one kind of pollen, it's a lot of things that our immune system is bombarded with. So patients are sensitized to pollen in the natural environment and thus become sensitized to several types of grasses. Clinical symptoms in patients are caused by allergens from multiple grass species rather than just one grass species, such as Timothy grass, as we said. And our patient, Sam, is an example because he has 3 different kinds of grass species to which he is highly sensitized. So this goes to the composition rationale behind the AIT. Grass pollen allergic patients are naturally exposed and sensitized to multiple pollens from various grass species, and the molecular variability of allergens between different grass species are significant. And as such, for optimal treatment outcome, it is important to modify the immune response to all relevant grasses. And hence, allergen-containing grass mixtures is preferable from the standpoint of immunological effectiveness and also patient adherence. We don't use the word compliance that much because it kind of has, patriarchy involved. So the adherence to therapy, something I spent a lot of times to make sure I maximize, is a function of multiple elements, one of which is to simplify the treatment, and as such, having an allergen containing multiple grass mixtures is preferable. So advantages represent the natural exposure and sensitization conditions for patients with grass pollen allergy, contains an optimal amount of both major and minor allergens, and expands the spectrum of T and B cell epitopes compared to pollen of a single grass, and provides the best clinical response, as we can see. So the composition rationale is based on the fact that grass pollen immunotherapy should be carried out using biological extracts made from a pollen mixture rather than from a single pollen. And that although the relative efficacy of a single mixed pollen vaccine has not been assessed in a comparative trial for obvious reasons, we infer from the present study that the latter would likely be more efficacious in the former, and that this study suggests that multiple grass pollen species immunotherapy should be more beneficial than single species immunotherapy, and as such, mixtures are better, and this recommendation is often found in the literature, and they are listed at the bottom of the slide. So there is clear agreement, opinion of international experts, that it is recommended to use a mixture of different allergens within a homologous group, in this situation, grass pollen, for optimal reprogramming of the immune system, especially for the achievement of the carryover effect. So the differences between pharmacotherapy and AIT that we have, I think, gone over and proven. Pharmacotherapy only reduces allergy symptoms and controls the symptoms, but cannot and does not prevent the development of new allergies and allergic asthma. And after discontinuation, obviously, since it's just a controller, symptoms will return. And this, again, means that it must be taken for life and probably escalated. The AIT affects the cause of the allergy, so you're treating the root cause. AIT is the only treatment method that can stop the development of allergies, and this is limited to a 3 to 5 year course. I personally usually go with the intense therapy, and most of my patients at 3 years can actually stop their treatments, and they usually have a carryover effect that extends over years. As
Dr. George, we can't hear you.
Witness. You cannot hear me?
Yeah, now you can, yes.
Okay. Good. Don't give me such a hard time. So again, we're talking about different treatment options with different objectives that achieve a different outcome, which in this situation is cure as compared to just control. Dr. Pastorello, in her study, which was a multi-center observational real-world study evaluating the efficacy of 5-GRAS 300 IR slit in patients that were unresponsive to pharmacotherapy, found that in her study, which started with the retrospective arm, then a prospective multi-center observational study on the effectiveness of her 5-GRAS 300 IR slit in patients with grass pollen that were not responsive to pharmacotherapy. Inclusion and exclusion criteria were standard, but one of the important exclusion criteria was that the ARC caused by co-sensitization that can affect symptoms during the study should not be included. In other words, you should aim for something that you're covering. I think this is obviously clear. And this is the design. So you had a retrospective phase, the grass pollen season, identification of patients that are unresponsive to pharmacotherapy. And then she went with a prospective arm for the 2011 grass pollen season. And this was the prospective phase. And the endpoints were two. The primary was the effectiveness of a first year of slit in patients unresponsive to drug therapy. And the secondary endpoints were rescue medication use, impact on concomitant diseases, and the patient satisfaction through a visual analog scale. And the duration of that study was 6 months. And this is what it showed. I will make it easy. If you look at the left-hand side and the graph, you will find two, large bars. You have on the left-hand side 72.3% in the before slit population that had moderate to severe or persistent symptoms. And after slit, you will find that it's almost the same percentage that became mild to intermittent. And if you look at the right-hand side, you have another set of bars before and after slit, and you will find that the medication score before and after, so utilization, dropped by 42%. So the results were that 2/3 of patients with mild or moderate to severe persistent AR before slit changed to mild intermittent AR after slit with a very significant p-value, and there was a significant decrease in the mean medication score of 42% post-treatment. Patient satisfaction, obviously, after slit was very high and was very significant, as can be inferred from the slide. So before starting therapy, it's important to address very important points with the patient or the parents if you're dealing with a pediatric patient. And I think I've gone over most of those elements, but I think if I were to leave you with an important message tonight, it is that the discussion with the patient at length about important elements on when to expect benefit, when the benefit will be maximized, and the carryover effect of that treatment, along with the need for other control medications. These are very important elements to discuss with the patient in a discussion that should be done prior to initiation of sublingual immune therapy. So we should talk to patients about the short and long-term goals of AIT, the onset of action of AIT, and the AIT duration. I will go over those in a bit more detail. Horak, in a study done in the allergen challenge chamber, so this was a controlled exposure study. It was a randomized, double-blind, placebo-controlled trial on about 90 patients. It was a multinational study, single-center, in controlled conditions of an ACC, evaluating the onset of action of 5-GRAS 300 IR administered once daily to adults suffering from grass pollen rhinoconjunctivitis. So looked at the treatments, Duration was 4 months. Primary endpoints was the average rhinoconjunctivitis total symptom score, or ARTS, with a scale of 0 to 18. And the main secondary endpoints were ARTS at each challenge, and the safety obviously is the most important. And I think it's clear that within the first week, you can see a separation between the two graphs. And at 1 month, the separation becomes clinically and statistically significant. And not only is it maintained over the 4 months, it actually increases in terms of its effectiveness at the 4 month point. So it was clear that the benefit was in a controlled environment at all those outcome measures proven. When you look at the efficacy and carryover effect, and I think this is one of the most important slides to me, at least, it's that the carryover effect was very clearly maintained without a drop in the efficacy. So there was a maintained efficacy of the 5 grass 300 IR with a significant reduction in daily corticosteroids versus placebo over 3 years of pre and co-seasonal treatment, and stable daily corticosteroids over the 2 subsequent treatment-free years, demonstrating a carryover effect of 5 grass 300 IR for up to 2 years after treatment cessation. And this is, I think, very important. The carryover effect now is proven to be much longer than that, but I think it is clear to us, and that's what we should share with our patients, that we are aiming at making sure that after they stop that sublingual immunotherapy, the benefit is carried. So AIT treatment allows to reduce the severity of ARC symptoms and the medication use across patient populations from the different pollen season, with maintained efficacy and carryover effect for up to 2 years after treatment cessation. So we have short-term efficacy with reduction in the allergic rhinoconjunctivitis symptom severity, significant reduction in rescue medication use, with long-term efficacy demonstrated over 3 consecutive pollen seasons while on treatment, and carryover effect after treatment cessation proven over 2 years in this population, in this study. So which forms is better to choose? Is it the liquid sublingual immunotherapy? Is it the sublingual tablets? Is it the sub-Q immunotherapy? I personally, I favor the sublingual immunotherapy that's liquid for multiple reasons, and I think this slide will clarify those. The development of adverse events is the reason for discontinuation or non-adherence, not only of SLIT, but most medications that we use in our daily practice. And in SLIT in particular, it is up to 40% of cases. The gradual increase that the sublingual liquid allows in the dose makes it possible to get used to the allergen, so make it stepwise and make the change or the side effects much more palatable, and until we reach the recommended target dose. And only an allergen in the form of drops can allow such an opportunity. And this can be significant in pediatric population because kids are more difficult in that respect. In patients with high sensitivity that may have a lot of reaction to the other forms of immunotherapy, an allergen in the form of drops is easier to administer as a second allergen, and also we can titrate up and down, and it makes it possible not to stop AIT during the pollination season and exacerbations of complaints, where patients can reduce the dose and adjust it following their doctor's recommendations. So, takeaway points: AIT should be offered early to patients with allergic respiratory diseases. Waiting will only exacerbate the problem and increase sensitization and add other conditions such as allergic asthma. To treat symptoms, not only are we controlling them, we are actually treating the root cause and as such achieving cure. Prevent the evolution of allergic conditions, as we've shown in the multiple studies with the clear evidence towards that end. Decrease medication use in both forms, the non-steroid containing and steroid containing medications, and obviously improve quality of life, as was proven in all the studies that we've shown. With that, I thank you, and I'm not sure whether we're going to take questions now or leave until later, but I will stop sharing my screen.
Excellent, Dr. Jovelikian. That's excellent, succinct presentation, and thanks very much. And despite the
Thank you,
internet interruption, you managed to keep in time. So that's fantastic. Now we keep the questions to the end. So we'll please again, participants, just to encourage you to send your messages or questions, comments to the Q&A, so we can discuss them later. Okay, so we'll move to our second speaker, Dr. Khalid Al-Saad. Dr. Khalid, the floor is yours. Thank you.
Thank you very much. Let me share my slides. Okay. All right. Thank you, everyone, for your attendance. And George, as usual, it's a pleasure always to listen to you.
Thank
Can
you.
you hear me well?
We can
Yes.
hear you.
Okay, good. Right. So my talk is more of a pulmonary, most probably, rather than of the immunology. It's very exciting for me, and I think for the pulmonologist. A small introduction, which is the first slide, is when we have our patients who present to us with allergies, it takes us a while, all of us as doctors, to identify them very well. As you can see, we have patients who, I don't know if the cursor shows you that, but usually most of our patients, they go to their primary care physicians. I'm talking mainly on adults now. And it takes them a time until they meet their their specialist doctor, whether is that a pulmonologist or an allergist. So, and on average, this is as usual. Usually nowadays, most probably takes around 2 years. There's some data like the one we're seeing here from 2011 takes up to 8 years or 8.5 years to find and identify their real status of allergies as well as what are the allergens they are exposed to, how to handle it. So it takes a while, and during that time, of course, the patients are suffering. My first part of this talk is about really immunotherapy and asthma. And as you know, the major problems we're facing with asthma today is that um, the triad of having a lung function abnormality, having the expiration rate, as well as having repeated corticosteroid therapy. So the question is, part of it was answered by George, is that can immunotherapy, can it affect all these? Can affect the exacerbation? Can it decrease the corticosteroids? Can it control the asthma better? As well as can it can prevent asthma from happening? So if you look at the people who have symptoms and they are exposed to allergic immunotherapy, we can find that looking at this graph, we can see that it tends to favor the use of immunotherapy in patients in order to symptoms. And controlling the symptoms is an important part because if you remember the GINA guidelines in the management of asthma, identifying what is asthma controlled versus uncontrolled, it really depends on the questionnaire. Questionnaire is more of an objective rather than objective. So controlling the symptoms, most probably you are controlling asthma. And this is true for children or as well as for adults. And again, I'm not sure if the cursor is on, but you can see the adults showing that it is favors that as well as children. So we have a good data today that the immunotherapy can control asthma symptoms, which is part of the treatment that we all aim for. But does it affect also the plan of our asthma? Whereas you know that when we deal with asthma, we go to the step up and step down, and we're trying to see if we can go to the step down and trying to control asthma and down the inhalers in particular. And this is that important to us? If you remember, we used to say that inhalers are not absorbed and we don't care that much of how much you use of inhalers. Clearly, we do have a higher dose, and most of the times we say that the highest dose of inhalers or budesonide or whatever, or fluoxetine, these are really, as you go up, there's no more effect. But do we get absorbed? Do we have side effects of it? This continues to be a controversial. But today, we do have some good data that shows that if you take budesonide more than 600 a day, it has an impact on our health. In children, it delays the growth spurt, but then it can follow up. We do have now data that affects many of our general condition, especially osteoporosis, fractures, and so on. But really, if you look at some of the data that has been published recently, it does affect even increases the incidence of arrhythmias and cardiovascular morbidities. So even inhalers are nowadays of paramount importance. So it is important for us now today to try to see if we can control the inhaled corticosteroids and try to see if we can cut down or go down on the step down the inhaler doses. And to do that, of course, this is done in a teamwork, and the patient is the center of that team that deal with. If we can control the treatment, then can we call the exacerbation rate? And this, I think, the most important thing, and that's where current immunotherapy, as well as the biologic nowadays, is to talk about the exacerbation and cutting down the exacerbation rate. Because as we know, as we go with asthma, with a mild, moderate, or severe, mild asthma, the exacerbation rate is significant. And they are, if you look at the number of patients who go to the emergency room, most of them are the mild asthmatics. And they almost comprise about 10 to 30% of the mortality of all ER with asthma exacerbation. So controlling the exacerbation is important because it will avoid going to the ER and morbidity, mortality as well, consequences of it. And this is where can immunotherapy help us with that also or not? The aim of all of us, if we can reduce the inhaled corticosteroids and try to not to substitute medication, whether to go with leukotriene modifiers or going with a long-acting clinic and long-acting agonist. And other options we have some days is that can we use biologics? Today in the Middle East, I think we have, at least in my area, we have the omalizumab as well as um, in biologics. But what George mentioned is that if you have immunotherapy, this is, I call it the bullseye way of managing the asthma. And if that's really successful, then most probably the most important factor, for example, a house dust mite, where you are exposed every single day for it or to it, then your asthma is gonna, and the inflammation is gonna continue. So are you modifying the risk factors or not? I think that's one of the most important. So today, if we can control our asthma well with immunotherapy, we most probably will be able to try to manage the day-to-day symptoms and decrease these changes that we have the diurnal variation and causing the exacerbations. And that's what, if you remember, the GINA looks at. So we have this most important thing is the headline is that we want to control things in a well-controlled asthma for the next 3 months before we start to go. The individualized one is to talk to patient and look at day-to-day changes. And most of the people, as you know, they measure the asthma by the um, the the study that was quoted by George continues to be a very important study because it has shown that for a patient taking a total of 100,000 in the immunotherapy compared to almost 300 in the control, and looking at patients with history of asthma and can we go to the step down? If you remember, George mentioned that this a real world study, and its study is showing that can we prevent asthma from happening or decrease the progression asthma of becoming severe or not. And if you look at the data here, again, it favors the efficacy study. You look at the data, it favors the use of immunotherapy, and you can see that based on that 50% step down in asthma treatment. So this is one of the largest studies ever done and showing a positive um, um, positive effect on using immunotherapy in order to cut down or step down the inhaled corticosteroids, trying to decrease that dosage. And again, if you look at this is a Chinese study that was on patients who are on high dose, around 400 micrograms, and they were taking the immunotherapy, and the idea was to see if they are well controlled asthmatics versus totally controlled asthmatics and the use of the asthma questionnaire or asthma control questionnaire. And you can see in the blue line compared to in the gray line or gray whitish line, the placebo one who did not take immunotherapy, those who took immunotherapy, you can find a big difference in those who took the slit, and they have more well-controlled, more totally controlled, and the asthma questionnaire is favoring the slit. And you can see that if you look at the reduction in the symptomatology, it was quite significant in those patients. So is the potential role of immunotherapy in reducing asthma exacerbation? Remember, we said that we have asthma exacerbation, we have the oral corticosteroids use, and we have also the lung function and deteriorating lung function in patients who have persistent asthma and start to become in the severe one. We know that we will have a drop. And again, this comes from the same study, from the efficacy study, and you can show that the whole idea is, like we said before, is number one, can we prevent asthma or delay asthma? And number two is, can we have trying to control the asthma is not becoming severe? And we know that as you look at the exacerbation rate in asthmatics who are severe asthma, the exacerbation rate in some studies reach up to 29%. On average, it's around 6 to 8% annually, compared to a mild one, which is less than 1%. So there was in the study again favoring the exacerbation control, and you can see that whether you with different age, sex, and house mite or grass or ragweed, all of them, they have shown that the use of immunotherapy was done, of course. There was almost a 36% reduction in new asthma events. And comes is, do immunotherapy prevent asthma? I think George alluded quite eloquently to that. And I think we all remember when we had the challenge test, methacholine challenge test. And I think one of the studies now I cannot quote, was it done? I think it was done in the late 1990s, I think 1998 or 1999. The study have shown that patients who have asthma, patients who have allergic rhinitis, and one who took immunotherapy and the other one who did not take immunotherapy. And those who took immunotherapy, their methacholine challenge test were more controlled compared to those who did not. Was, if you remember, the challenge test is predictive. We do have some initial studies that tell us that if we get immunotherapy, most probably we will delay or quote unquote prevent asthma. And this is, again, it's about grass, and we can see that in children with immunotherapy for 3 years, and we can see that an improvement of quite impressive, a decrease up to 18% only will develop asthma development. And again in children, another one for 2%, and again 15% all in all in adults. So quite impressive data that you can delay asthma or at least prevent asthma. And these are different studies. And if you look at asthma prevention for this is a meta-analysis, and again left to the graph, you can see that it all favors many studies, whether we're going from 2006 up to 2020, they all favor that starting immunotherapy will delay the asthma onset or can prevent asthma. And this effect was larger in children, and the big topic is the monosensitized, as well as for a good duration of therapy, is years. This is the breathe study or the breath study, which was done in France, which is again a real-world study. It is somewhat the concept was alluded by Jack, which was a 5-grass pollen slit versus a 1-grass pollen slit. The impact, initiation of asthma use. And there are patients who were allergic rhinitis, and another group were allergic rhinitis to asthma. the number of patients were around 1,000 plus, compared to the control were almost 7,000. Quite a good number. And the duration of therapy was 1 year to 2 years. And you can see that some people took 2 seasons and some people took 3 seasons. Around one third took 3 seasons, and around uh, um, and there was different age on those patients. There were some people, even some were above the age of 45. Clearly, it shows the how favorable slit is, and you can see that there is a good reduction with a good p-value for those patients. The initiation of asthma medication was quite delayed. Both groups, the 5-class, in particular the 5-class, so um, the 5-class pollen slit patients were the only patients who significantly reduced starting asthma who did not. So this is, again, you can see that this is continues, that the slit reduces the risk of initiating asthma by up to 64%. Quite nice data. And the something that we hear about it in the conferences quite often is the guidelines. And we all, to some extent, the most popular guideline till now is most probably a guideline, being more of a global guideline. And we've all have seen that there are few changes, some of them that are related to patients, the preferred use of inhalers and the combination of inhalers. And if you look at a very famous study, which was published in the New England Journal of Medicine, about the use of mipopilab, which is one of the one of the biologics, and versus a control. And despite the fact those were severe asthmatic patients, yet patients who in the control, up to 30% of them did very well without using biologic, because they started to use their inhaler in a good technique, despite the fact they come from centers, they refer to that study centers, and they are defined as severe asthma, but seems that they were difficult to treat asthma rather than asthma. Now, if you look at what's new, we can, the step 5, of course, you can see that typing our patients is very important. Yet, from step 1, identifying the patient allergy is important. And the GINA has put house dust mite as one of the most important, or the most important allergen, and that is because of the daily exposure, the continuous exposure. And most probably the load of that exposure is very high because you're quite close to the origin, which is the house dust mite in the mattress and in the pillow. So this was quite clarified by the GINA, that identifying the allergy status of your patient, of your asthmatic patient, is important, because that was a controversial issue before. Should all asthmatic patients have an allergy profile? Clearly, yes. Number 2 is identifying the house dust mite as a culprit is important. Americans, they do identify that any type of allergy that you believe is responsible for the uncontrolled asthma, you consider immunotherapy for those patients. And today, the guidelines is very clear, is that this is the IACI guidelines. If you have an uncontrolled asthma, or you have a partially controlled asthma, or you have a controlled asthma, and you look at in the uncontrolled asthma, you can achieve a control using a house dust mite immunotherapy. In a partially controlled asthma, adding one also will facilitate asthma control. And even a controlled one, adding an HDM immunotherapy can decrease the medication requirements and make the patient more controlled. So this is the introduction. And if you want to identify your patient, whatever the allergen is, patients with high eosinophil count are more responsive. Patients who are on inhaled corticosteroids and they show response, they will be more responsive to immunotherapy. And asthma clearly is an airway disease that can be responsive to immunotherapy. George talked about rhinitis in excellent book, and then having both the dual response will be quite. So in conclusion, for the first part, allergic asthma is a global problem, and I think that was alluded with our first speakers. You know, if you look at other studies, whether the allergenic studies and others, the allergy or the asthma is around 60% of the population in the MENA area. So I look at Jordan, which is 12 million. So we're talking about 1 million people with asthma, and clearly we know that many of them are not controlled. Currently, we know that based on the data we have, that treatment of asthma is well established using the AI, using AIT. Treatment is a well established methodology, and it can help us in stepping down the asthma treatments, especially in health controls. Recently have shown that even cardiovascular complications are well documented when you use a high dose steroids. And the hallmark is asthma exacerbations, just like exacerbation. Exacerbation is very important because of mortality, morbidity, and loss of function and expenses. And we now know that using immunotherapy does decrease the rate. And can we prevent the asthma versus we can delay asthma, as was said before? Yes, we can. And currently, the international guidelines are in favor of AIT. I think this is just a case that I just had a case similar to that. And Sarah always is a quite big helper for me or to me, and she helped me with this case in identifying the allergy. This is a case, not my case. This is a 46-year-old who comes with a blocked nose, rhinorrhea, disturbed sleep, snoring, tired all day, which is typical the quality of life in patients who are with severe nasal symptoms. And you have this night cough, which could be part of the post-nasal drip or maybe a type of asthma. And all the year round with worsening complaints, mainly in the summer. It seems like we have two parts of his allergy exposure. And an endoscopy, as you can see in the CT scan, quite an impressive nasal deviation, which will add to his problem, and clear sinuses, a FeNO that is quite high, and a lung function having a positive allergy to a house dust mite, which is all year long, as well as Timothy and pulmonary, which could be. And these patients are uncontrolled upper airway. He's having this continuous symptomatology. And this could be partly a disease-related factors or a patient-related factors and a diagnosis-related factor on the and think so on, so as an obstructive component. And then comes the treatment-related factors, and usually it's trying to understand that sometimes just go for an easy, fast, and cheap, rather than looking in the depth of the data we have, similar like the allergy that is exposed to. One is all year long, and one is or seasonal. So sometimes we miss on those patients. If you look at patients with allergic rhinitis or persistent rhinitis, the use of decongestants is quite impressive. This is similar to the use of short-acting beta agonists in asthma, where it is overused, and we know the hazard nowadays of using of decongestants or using of a short-acting. And unfortunately, if you look at the end of the slide, you can see that 3% of patients with allergic rhinitis, they use even glucocorticoids, systemic, oral, and some of these injectables in Jordan, in a very famous one called Diprospan, which has two timing for it. So the patients wanted to be treated, and the question come, and I think don't have a full answer, but would you go for septoplasty, turbinate surgery, or would you go with the treatment, whether a nasal corticosteroids with an inhaled corticosteroids, or would you add an asthma control approach and using the housesmite versus the grass? Most probably, I'm sure a big discussion and everybody will have a different opinion, but it is very tempting to start all the symptoms with the inhaled glucocorticosteroids as well as in housesmite, knowing that housesmite will take time to get in, but usually well controlled. Usually, I would just use or ask our colleagues in the ear, nose, and throat is to see those patients and to see if the impact of plasty and turbinate surgery, how much will symptomatic. The second part is a short part. This is the polysensitization, and clearly we don't have still data, but George talked about part of the data we have, and I'm going to talk about another part, and they are all encouraging sensitization. So just like our patient we just talked about. So is there evidence of the effectiveness of immunotherapy in patients? And this was an international consensus on immunology, which shows that almost 80% of our patients will have a polysensitization. I think that's probably what we see in our practice, just like the case we had today. This patient housesmite, olives, grasses, and we see all in our practice. So this real life issue is that polysensitization. Now, sensitivity to not all identified allergen is of clinical significance, and I think that we agree on that. And immunotherapy is most probably equally effective in both monosensitized and polysensitized. Know how to treat, how to select, and when to start, which one to start first. Now, if you look about effectiveness, you can see that the upper part is about patients who had the immunotherapy for monosensitized, and on the lower part is the polysensitized. And you can see it all being favored. All the graph is coming to the left, and we have a similar efficacy in mono and polysensitized. So it seems like, yes, they are both are effective, but again, is we need to really choose which one we're going to start based on our, like Muhammad mentioned, or that we need to choose well based on good history and then having lab data to support. Allergen to start is always a big topic. Clearly, a simple question, a simple answer is you are the most clinically important. I remember we used to have some patients coming from Libya, and they would be positive for olives, and they've never had or contact with these. So I don't think that would be fun. If you look at the patient I had today, housesmite, it's clearly this guy is having all year long symptomatology, occasional, seasonal. Then I would look at the all year because I want to control his asthma, control the exacerbation, avoid corticosteroids, function. The patient had an around 5%. So I think it's, if you want to look at it, the first year is the most clinically important. The second year is start the treatment of the second, and then you have to reevaluate and see where you are heading. So it can be done, and this is if you're looking at the split and you want to give two polysensitized patient you want to do different immunotherapy at that time, one could be given 30 minutes before the other, and or you can give one in the morning and one at night, but not before, because you don't want them of an increased histamine release because patient develop a wheezing night. So usually just at bedtime, nighttime, but not at bedtime. And We do currently seems like George said, we show that there is an improvement of life and rescue medication will decrease, especially in asthma, SABA, which is associated with more mortality, and the symptoms control. So those patients who are polysensitized can have a good effect from immunotherapy if you knew how. So I think this would be my last slide. The first part is that us as clinician to understand the respiratory allergy and the burden of it on our patient, then trying to improve the patient outcome by better treating them as a global treatment, understanding for us asthma and this relation with the rhinitis, as the area have shown that there are three stages, and stage three, where each one now is become separate, where rhinitis will affect asthma, and to some extent, asthma might affect rhinitis. Trying to understand this in a global manner, and trying to understand the patient, he or she, how much they can be commitment or and not to abuse also treatment. And number three, if we have patients with allergic rhinitis, and we use the early prevention and early treatment, this would be really of a paramount importance because if we can early prevention and early treatment, as was mentioned before, is probably you can either delay asthma or prevent asthma. If you're already asthmatic, you can delay to prevent the progression of this asthma, and more important, or as important, is control the exacerbation rates and prevent exacerbation. Thank you very much.
Many thanks, Dr. Khalid, for your excellent talk, highlighting the importance of allergen immunotherapy in asthma and bringing the issue of polysynthesized individuals, because this is really an important aspect that we see in our daily practice as allergist immunologists. I mean, we hardly see monosensitized individuals. I mean, it's really most of the patients that we deal with are polysynthesized, and it's tricky to identify the most relevant allergens. So you've highlighted and touched on points there that are important for managing these patients. I'd like to thank our excellent speakers for really very informative and interesting talks, and the floor is open for questions. But before I go to the audience and participants' comments and questions, I just wanted to ask maybe Dr. George about how would you convince a patient with seasonal allergic rhinitis to put them for 3 years, let's say, on a treatment that they need to take every day for seasonal symptoms? I mean, how would you convince the parents of a child, with seasonal allergic rhinitis to grass, for example, to take this medication all year round, while their symptoms only for a short period of time, and then they're basically free from symptoms, and you're asking these patients to stay on treatment for 3 years continuously? How would you convince these patients and parents to keep taking the medication? And do you have any issue with compliance or adherence?
Yes, thank you, Professor. I think this is that's where the rubber meets the road, as they say. This is the most important element. If you do not convince them about the importance of embarking on this journey of proper desensitization, in other words, taking it for the 3-year period, then they miss the most important element, which is achieving the carryover effect. In other words, the cure part. And I think that's where Heidi, this is the carrot at the end of the stick, if you will. First of all, I take time to explain the pathophysiology of their condition. In other words, we're not dealing with itching or sneezing or coughing or wheezing. We're dealing with an inflammatory condition that affects the airway, that has repercussions on their long-term well-being, and more importantly, that requires multiple controller therapy, and an important central ingredient of which is corticosteroids. And I think this is a very important element that gives, you have phobia that parents have regarding their kids taking steroids long term, and it's well founded, if you will. So this is one of the elements I use to explain to them that corticosteroids are amazing tools. They're amazing medications if used properly. However, if we have the option of saving their child from needing controller medications, including corticosteroids, year after year, season after season, forever, and the potential of needing more of it later on, if they go through the atopic march and they develop other complications like asthma or the food allergies or whatever, this is the way I explain to them that we're dealing about modifying their kids' disease and the worth of going through this treatment modality. Most importantly, also because of its safety. So you focus on changing the disease condition itself, and then you focus on the safety of this treatment modality and its flexibility. This is how I do it. And I tell them, honestly, doc, I tell them, if you don't believe you're gonna have your kid adhere to this therapy for 3 years, don't start it. It's fine. If you want to think about it, take your time. There's no problem. Really, I know you're gonna pay a higher price by waiting, but if you do not comply with the or adhere to the treatment duration, then it will be lost. And with adults, it's a bit easier. That's my last point. It's a bit easier with adults because the adults today, I saw a patient. She has been having symptoms for over 30 years. When I told her 3 years, she said, "What? 3 years?" I said, "How long have you had the problem?" She said, "Since I was born, probably." I said, "Well, 3 years and you'll forget about it." So it's a very important selling point. I think the key element is education. The more education based on scientific evidence, the easier it is.
Thank you very much indeed. Totally agree. Dr. Khalid, how would you see it, in the era of plethoric biologics, how would you see allergen immunotherapy as a treatment option for patients with severe asthma? And do you think allergen immunotherapy with conventional asthma medication can actually help patients with severe asthma?
Yeah. Somewhat I knew this question is going to come. Well, number one, you've already answered one part of it, is that it's severe asthma. So immunotherapy is not just for severe asthma, from all the stages of asthma. So I think immunotherapy has the big advantage of that. Number two, immunotherapy is patient would be happy to use because he or she is part of the treatment. They are taking the slit and they are happy about taking it and contributing and participating in their own management. While the biologics, most of the time, they have to come to the office and they get the injection, and they're always concerned about this injection. The other part, which is very interesting, we forget about, clearly, I use biologics quite often, and clearly it's an amazing medication. But one of the things is that we don't have an answer when the patient asks you, how long will I'm going to stay on biologics? We don't have data on omalizumab, benralizumab, bipulizumab. We don't know when to stop them. So you're going to tell this patient you're going to take it, and then the patient going to tell you when I'm going to stop it. Tell them, I don't know. We don't have enough data. So you're going to use it now until you and I will discover with time. While in the immunotherapy, especially with the slit, that this is a 3-year program. And usually those patients, they're happy, just like George said, they will happy that, okay, 3 years, especially if you tell them that there's the stigma of the inhalers. If you tell them that the inhalers will be cut down and you might not become dependent on the inhaler as you used to be. I think there was a beautiful study that was done by the French, I think about in the early 2000s, where they used omalizumab and slit patients with the house dust mite. And they showed, of course, clearly, they showed much better results with using one of them or either. But again, I think the major issue is the 3-year versus no definite time. Anna, for me, just like George said, for me, and your introduction is that if I find someone with mono allergy, especially house dust mite, I usually grasp and just tell them, listen, guys, just sit and talk seriously about it. We have to solve this. You are one of the few, you're only 20% of the population who can you have mono allergen. Let's really grasp you, treat you very well. And, it's the confidence with the doctor and the relationship is very important.
Thank you very much indeed. Again, and we don't forget, because the way that biologics work is quite different to what onto how the immunotherapy works. I mean, allergen immunotherapy actually modifies the disease process. So, and this is what we aim for. While biologics are, I consider them as probably high cost antihistamines or whatever. So they don't really. Again, I don't want to go into that conversation. Because it opens a can of worms. But anyway, the cheapest option.
For pulmonologists, it's a controversial issue.
That's excellent. I'd like to thank our participants. We have 102, 250 participants, which is really great. And I'd like to thank them, thank their participation and for bearing with us, learning about allergen immunotherapy. So I'm going to take a number of questions from the audience, and the first question is to either of you. How do we taper controllers' medications? I think this is probably related to nasal sprays and possibly to asthma medications as well. So how can we taper? How do you taper controller medications?
I'm gonna start. So actually, it's quite easy, and that's what I told them. I did show that study whereby within a week you can see some benefit from sublingual immunotherapy, and after 1 month the benefit becomes clear, and at 4 months you have the clear separation, and that's what I tell people. Studies and data have shown that if you start the sublingual immunotherapy, usually in about 3 to 4 months you would have achieved enough quote unquote desensitization that controller therapy will no longer be necessary. And I've tried it in my own experience in my clinic and with my patients. The majority of patients feel the benefit after about 4 to 8 weeks. However, at about 4 to 6 months, so 4 months has been a good cutoff for me in having patients come to visit where they no longer were in need of control medications. They were not taking any histamines anymore, and they were able to taper down the inhaled intranasal corticosteroids by a big margin. Those who had concomitant asthma and were controlled on treatments, I was able to cut down on their treatment. And I personally am very much in favor of the step 1 GINA treatment, which is to give the formoterol containing medications and use the MART, the maintenance and the reliever therapy. In other words, I follow my patients closely, but I usually set the follow-up appointment around 4 months after initiation of SLIT.
Okay. On that note, did you start it at in your office? The first dose is to be taken in the office, yes?
No, I don't. Sublingual immunotherapy liquid? No, I don't, because of its safety. So when they start with the 10 IR and they escalated the first 5 days, and then they go to the 300 IR, an additional 4 days to get to the target treatment, by and large, they are it's smooth sailing. I have to make it clear to all our audience, and I really want to thank them for staying all this time with us. You cannot start immune therapy on a patient that has asthma unless you are confident by objective measures, doing a spirometry and your clinical examination, that their asthma is controlled. It's very important because you may be exacerbating their asthma. So it's important to reiterate the importance of controlling the condition, starting sublingual immune therapy. But I personally almost never start the medication in my office. It's not necessary. With sub-Q immune therapy, yes, you will need to do that. With those who are taking the sublingual tablets, they will have a bigger reaction the first couple of days. So I caution them against it. Sometimes they have to stop or they don't take it because of the side effects. But for the sublingual liquid, it has not been a problem for me, at least.
Okay, we really, to be honest with you, I take your points, but again, I think I don't have the courage to actually leave the patients, dispense the medication and let them start at home. All patients that I've looked after over the last 30 years or so, they come to my clinic and I'll give them the first dose in clinic. The issue most recently, we had 2 patients that we admitted actually because it's what is the tablets, it's what is one I'm not gonna say the brand, but anyway, we had significant swelling, facial swelling, lip facial swelling, as well as some shortness of breath
with the liquid or the tablet?
With a tablet. With a tablet.
Right, that's exactly what I'm saying. That's why, that's exactly my point, Professor. What I'm saying is that the beauty of the liquid is that the initiation is graded in a way that I personally have not had a single patient, and I have a pretty big population of patients that I've desensitized over the years. I have never had a problem with any of those who I desensitized with the liquid immunotherapy.
Now, the point I want to try to make here is that because this can cause significant reactions, because your experience, so our experience and the audience ranges, so I would advise that when we decide on these therapies, we have to be very, very cautious and very careful. So I agree with you totally. I wouldn't start this therapy in a patients with uncontrolled or partially controlled asthma, because that can exacerbate the symptoms. So again, these therapies work beautifully in a patients when you pick the right patients and you give them, this form of therapy based on history, based on testing. It works magic for many of these patients. Dr. Khalid, what's your view on tapering
asthma control? And I always have a problem with the concept because I'm talking about the control therapy, control medication, because we always depend on the questionnaire, or we depend on the symptomatology of the patient. So we always try to step up, step down based on patients' statements. For example, if they wake up at night and they used to, but again, this could be a partial sinus problem or could be part of a reflux. So I'm always weary about that and always very cautious when I take my decisions in cutting down or stepping down. Now, the beauty about stepping down today is with the GINA guidelines, which most of us follow, is that you can use your long-acting beta agonist with your inhaled corticosteroids as needed also. So I always, when I want to step down, I tell the patient, okay, you used to take two puffs, and we're going to take 2 puffs once daily. But remember, if you need more, you can take more. Just if in the next 3 days or 5 days you're taking more, please give me a call back. So till now, I used to have, for example, a nitric oxide in my clinic. Now we don't have the sachets for that. A flow meter is not very accurate, and peak flow is not very accurate, as well as a spirometry. You cannot do all the time spirometers for your patients. So in asthma, I'm a bit weary. I'm a bit concerned. I'm very cautious, and I clarify it in very obvious way that please, this is my number. You call me in the next 3 to 5 days if you need to use your PRN, long-acting beta agonists, and inhaled corticosteroids, or format with the more frequent than you use. I have also a good number of patients who took the slit. I think 3 or 5 of them had increased of numbness and itching in the throat as well as in the tongue, but none of them developed any swelling. I have to admit I've never used it in the clinic, but all of them always they have a contact number with me and my secretaries that if something happens, to call immediately. At that time, I would send them to the nearest ER if there's anything to be checked out, and then call me back. I think that's the major issue I had with the slit, is either numbness or feeling of discomfort in the tongue, but none of them had a swelling or angioedema or anything like that.
Wow, we have a very courageous pulmonologist, which is really
my name is Khalid.
Always.
More than that.
This is not the attitude of the allergist anyway. We're a bit coward, when it comes to So that's excellent. So that's good. Now the question to Dr. Khalid is about, again, the biologics and allergen immunotherapy in a patient's difficult to control asthma. So what's your view on that?
It's if you're talking about severe asthma or uncontrolled, there's a difference between severe and uncontrolled asthma. If you have a severe asthma and you phenotype your patients, at that time, then the use of biologics is of importance. I had two patients recently who had polysensitization, very unclear. They both had house mite. They had a high IgE. Eosinophils were not elevated. They are having a poor quality of life. And I started them on omalizumab at that time. I told them for the next 6 months, we're going to start omalizumab. And then we really study about using the house dust mite allergy immunotherapy. Um, Clearly, biologics have opened a new door of safety to our patients to control and to cut down. As I've remembered, the new study that was just published in Lancet have shown that you can go down on your ICS in patients with severe persistent asthma who have a high eosinophilic count. So I think the whole idea is like you alluded before, is that understand your patient, examine your patient, take a good history, and then, as I think the three of us agreed, the data is showing that once you have a good understanding of your patient, you put this plan, which is a plan for the next 3 to 6 months, based on the main issue is the inhaled corticosteroids with the LABA today, and then you reassess, and trying to understand and solve this mystery. Is it an event really is because of allergic component, but outside, but you are not well controlled, then just like George said, you have to step up a bit, or you step back a bit, start to study most probably a biologic at that time. And if that patient, based on his or her phenotypes of high IgE or a high eosinophil count, a positive allergy test in the IgE with IgE, then at that time, a biologic, whether a long-term biologic or a short-term biologic before reinitiating an immune therapy is quite accepted nowadays. And they're quite impressive, I have to admit, and safe. The data, the meta-analysis on omalizumab have been used even in pregnant women without any complaints or any side effects. So we have a good options nowadays, which is very nice.
Yeah, although we've no studies on pregnancy or lactation,
No. Meta-analysis.
Meta-analysis, yeah. So I'm certainly I've been using Xulers for the last 20 years or plus, and I've used it in pregnancy, and there's no issues now. I think because the biologics are very targeted therapy, so I don't think there'll be a significant issue anyway in pregnancy or lactation. However, we just go back to allergen immunotherapy, because if you open the door on biologics, we'll never stop here.
Never stop.
Now, just going back to the updosing. So there's a question here about: do you start your patients gradually updosing, or do you go? I think they're alluding to the cluster immunotherapy here, and how to manage adverse effects. Because I have a little story to tell you once I hear from you. So updosing, slow updosing, or do you do rush schedules for SCIT, for example? Dr. George?
Yes, so updosing in terms of a polysensitized patient, so more than one. Okay, well, what I do, I actually look at my patient's symptoms. I try to and identify the most important allergen, and I start with that one. So, for example, let's say I have somebody who has allergy sensitization, severe sensitization to dust mites and to wall pellitory, for example, and their symptoms are perennial throughout the year, but they are much worse during the if you will, the fall season. Those patients, I start them with the house dust mite, and after I have them go over the treatment for at least, I would say, 4 to 6 months. If they are better controlled, then I go ahead and I add another immune therapy for, let's say, a pollen in this situation, the wall pellitory, and then I go for each one of them, the 3-year period. In other words, I personally favor starting with the most important culprit, and then add the less important ones should the symptoms persist. Because in my humble experience, I found that if you attack the most important allergen, the benefit you get from those patients' response to the, say, house dust mite does actually have an effect on their symptoms from the other allergens. And it's a bit strange, even though these are not homologous, right? So even when they are not homologous, I see that the patients feel better, probably because the inflammatory cascade and the recruitment and all the mast cell sensitization and everything becomes less pronounced. So I personally phenotype my patient, identify a major target, go after it, give myself enough time to see a benefit, and before adding another immune therapy.
Okay. Now, yes, that happens. But remember, I mean, again, this is just stating the obvious. So allergen immunotherapy is very specific, but there is something called in immunology called bystander effect.
Yes.
Bystander effect is related to Tregs or T regulatory cells, which immunotherapy produces. So Tregs will dampen the effect of reactivity to other allergens, but it is not. It's a bystander effect, so it's not specific to that to those allergens. The main the main allergen that is affected is the one that you're given immunotherapy for. So, but you get, yeah, that's true. In some patients, doesn't happen all the time. You get this bystander effect, which is related to
yeah, but that's exactly my point, Professor. That's why I said that I give myself enough time to be able to appreciate if there is a bystander effect, because that bystander effect may be significant enough for me to forego the need to add another desensitizer. You know what I mean? In other words, I look at my patient, I phenotype, I take my time to figure out whether I'm having the best target for my initial desensitization, and then I let, if you will, the time course of treatment and the patient's response dictate how I do with further additional therapies or just staying the course. So as you said, it's not uniform, it's not for everyone, but it does make a difference. That's why I give myself enough time. I don't just attack from multiple angles at the same time.
Good. The question is both of you, but maybe you start, Dr. Khalid. What is the unmet needs in our, not unmet needs, but we know what the unmet needs are, but what are the challenges for our patients needing immunotherapy in our region? So I think our needs are a bit different to the West and to North America. So what are the challenges that we meet as physicians and as patients when it comes to allergen immunotherapy?
Yeah, very difficult question. Clearly, most probably each area is different. If you come to Jordan, the concept itself is weird for them. The culture of having an immunotherapy, despite the fact we always mention وداوني بالتي كانت هي الداء, but we do have a problem that the culture, patient and his or her family, they have a problem in giving therapy as a concept. They're not used to that concept, they're used more to a medication. Variety of antihistamine, variety of inhalers, corticosteroids, which is horrible. They are more popular. So number one, this is what I face. Number two is try to explain a mechanism of action in a simple words in this arena of immunotherapy is so difficult for some of the patients to understand how it works and what does it mean. Number three is that usually they are used to take antihistamines, which is available, cheap, and most of the time no side effects. Nasal steroids, unfortunately, many people take nasal sympathomimetics and they feel quite happy with that, just similar to a short beta agonist. So the availability and the price is a very important thing in Oman or in Jordan. We have a big problem with in Jordan in dispensing medications, because you can walk into the pharmacy and ask for a short-acting beta agonist, and get corticosteroids and antihistamine, sympathomimetic without a prescription. You don't have a problem. So the availability of other medications is important. Some of the so there are so many, but some of the things that comes to my mind also. Many of the patients today, especially the young generation, they are overwhelmed with work. Some of them they travel around, so having and using a slit every day without carrying it with them, big problem to them. They can take and this loratadine or a loratadine tablets in their pocket and just move around, and then they're at night or in the morning they can take it at any time. An inhaler they can take it any time, so it's more accessible in their daily life. And the slit is not that fast, but they have to remember when they wake up in the morning, if they're in a hurry, they have to remember that, wait, hold on, take your slit and then do whatever you want. And finally, in Jordan, expense, the availability of it. You don't find it in all the pharmacies, of course. That makes sense in Amman or in Jordan. You have to order it from the originator and to take it to the pharmacy or to buy it from there. And it is a load of or a big toll on the daily expense for the patient and his family or her family. We all argue that it decreases exacerbation, decrease the emergency room visit, decrease your inhaled corticosteroids, improve your quality of life. And after 3 years, you might not need medication later on. We all, as physicians, understand that, but the patient looks at the 3 years as a commitment. Years is of an important. I think these are the things that comes to my mind now, or my experience.
Excellent.
Yeah.
Dr. George, any more? Do you want to
Yes,
add?
if I may, Professor, because I think Khalid mentioned all the important elements, but I think there are two important points that I would like to reiterate. The first one is that education is key, but education is at two levels, sir. It's at the level of physicians first. Very few physicians, in my opinion, are aware of what we're discussing here. I'm talking in our field. I'm not talking about people that I'm not talking about cardiologists. I'm talking about pulmonologists. I'm talking about some allergists. I'm talking about GPs, family physicians, internists. Very few are versed in the even the idea of immunotherapy and desensitization. That's number one. So we have a job to educate ourselves as physicians, first of all, and make sure that we use science, as you mentioned, instead of myth or beliefs or whatever. And number two, we have to make sure that we translate that to the general population, to our patients, because at the end of the day, this becomes a benefit at the level of the public health. If you reduce the amount of medication use, like Khalid said, even from a standpoint of monetary standpoint, expense, you're going to be saving a lot of money on those patients if you properly desensitize them. So I think if I were to do one thing, it's going to be education at all levels, ours and then the patients at large.
I think that's a very important point. I don't think we'll finish with that. I think that's why we and pharmaceuticals in particular, Stalagen and Greer took this initiative to try and educate ourselves and educate the others in pulmonology, primary care, ENT, allergy, etc. Like you said, this is what I call the unmet need, is lack of education. A lot of doctors in our field, unfortunately, even allergists, they sometimes the idea of allergen immunotherapy is not entertained, and there are various reasons for that. But it's really education and is the key. And at this point, I'd like to thank Stalagen and Greer for allowing us to take this platform and talk about this important therapeutic option. I think we'll leave it at that, and I'd like to thank you sincerely for your excellent talks, excellent discussion, and really it was really an eye opener for me, and I've now know two courageous pulmonologists in our region.
Thank you very much.
Allah يخليك.
Very well informed, very well versed on immunotherapy. And it's really great to know, and I hope to meet you in person at some point. Like once again, thank Stalagen and Greer for their contribution and their support and giving us the opportunity to meet virtually and discuss this important issue. I'd like to thank sincerely our participants who we still have about 240 participants still with
Amazing,
us.
honestly.
Because at this hour of the evening, so I'd like to thank them sincerely, and please stay tuned. There's more to come, more interesting stuff to come next month, and until then, I wish you all the best and have a good night and
Good
enjoy
night,
the rest.
everyone.
Thank you very much
Night.
indeed. All the best.
Thank
Take
you.
care.
Thank
Bye.
you. All the best. Thank you.